you very much for inviting me. Good afternoon from Spain. It's amazing that we can communicate in this way. I'm rather new on this, but I really appreciate your efforts in trying to link all of us with you today. The oncological thoracic community around the world never had better guidelines as those that we have today. Both the North American, the American College of Chest Physicians, and the European Society of Thoracic Surgeons guidelines are based on the best evidence that we have today. They both agree in many points, in many issues, because they are based on the same evidence and the same publications. One thing in which they fully agree is on the indications of invasive mediastinal staging when there is no evidence of metastatic disease. And whenever there is any suspicion of mediastinal involvement, be this by the size of the lymph nodes on CT or by the abnormal PET uptake, then the invasive staging is indicated. To start with, if the EBUS is available, the indication would be to start with an endoscopic technique, EBUS or EUS or their combination. But they also agree that if the results of these endoscopies are negative, they should be confirmed with a surgical invasive staging technique, most commonly with mediastinoscopy. The ESTS guidelines have this algorithm that summarizes very well the most important situations that we can find after the first staging method, which is CT and PET or the combination of both. And we can have two possibilities. On the right, you have positive mediastinal lymph nodes, that is large lymph nodes, or positive on PET scan. And then if available, you can start with EBUS or EUS. But if the results are negative, then you should confirm with video-assisted mediastinoscopy, which is the recommended technique by the ESTS. And this is so because when you have large lymph nodes or positive on PET scan, the likelihood of having metastases on those lymph nodes is very high. So you have to confirm the negative results of EBUS-EUS. On the left hand, if there is no suspicion of nodal disease by CT or PET scan, you can find these two different situations. First, central tumors larger than 3 centimeters, or a clinical suspicion of N1 disease, or adenocarcinomas with a high PET uptake. In this situation, you also start with EBUS or video-assisted mediastinoscopy, depending on the availability. And then if these techniques are negative, you can proceed to surgery. On the left hand, if there is not even suspicion of N1 disease and the tumor is small and peripheral, then you can go directly to surgery. You can see here that staging, clinical staging, is a really multidisciplinary task. You have on the top, you have the radiologists and the nuclear medicine specialists. Then you have the pulmonologists who usually practice EBUS, and many pulmonologists also use the bronchoscope to perform EUS. And then the surgeon who usually performs video-assisted mediastinoscopy. The pathologist is everywhere. I mean, they have the last word on the study of the specimens that we provide them with. These guidelines have been validated at least twice. And you see here two different publications that deal with populations with different prevalence of nodal disease. But most important thing is that the negative predictive value of both is very high, over 90%. So what happens if we don't follow the guidelines, if we do not stage the mediastinum according to the evidence that we have today? then we find surprise N2. And Frank Detterbeck has published this important paper, very clear paper, has identified 3 types of surprise N2 disease when we do the lung resection. The first is the unsuspected, and that means that there was an adequate clinical staging according to the guidelines. But then we have the underappreciated or the ignored, in which there was either possibility or high suspicion of nodal disease and nothing was done. So these 2 circumstances are not really acceptable in clinical practice. Only the first one can achieve prolonged survival because the nodal disease that we will find is really small. So on the left, you can find negative prognostic factors of pathologic N2 if the clinical mediastinal staging is not done correctly. You are very likely to do an incomplete resection or to find multi-station N2 or level 7 N2 disease. And all these situations, are associated to very poor survival. None of those reaches 20%, and the 20% 5-year survival, you can achieve it with chemoradiation. On the other hand, on the right hand, you see the positive prognostic factors. If you stage the mediastinum well, you'll probably do a complete resection. You'll find single N2 disease and with a very tiny volume of metastasis. And then in these cases, survival is much prolonged. In our own institution, we have followed these ESTS guidelines even before they were published. And we have a low PN2 rate, 8%, which is below the 10% that the ESTS guidelines accepts as good enough. And you can see that these patients with minimal PN2 disease after inadequate staging had a very high 5-year survival, 40%, which is much higher than the percentage of 5-year survival when you do not stage well the mediastinum, when you find multi-station nodal disease or macroscopic nodal disease, and so on. But on this algorithm, there are 2 points that need further mention. In this arm of the algorithm, you see that EBUS EUS is at the same level as VAM. And if you read the paper, you will find a footnote indicating that this is so depending on the experience of each institution. That means that if your negative predictive value of EBUS EUS is similar to that of your mediastinoscopy or greater, then you can believe, you can accept the negative results of EBUS EUS. But if not, then you have to confirm the negative results of EBUS with mediastinoscopy. And this is so because there is a growing body of evidence indicating that EBUS in the context of clinical N0, N1 has a very low sensitivity and a negative predictive value, which is lower to that provided by mediastinoscopy. And in the lower part of the table, you find a recent paper published by De Calouvet and co-workers, in which they indicated video-assisted mediastinoscopy or video-assisted mediastinoscopic lymphadenectomy, VAMLA, in this situation, clinical N0 and N1. And you see that the negative predictive value and the diagnostic accuracy of these surgical techniques is very high. Dr. Zielinski will probably tell you about TEMLA. TEMLA is even a more complete exploration of the mediastinum, but we perform VAMLA in our institution, and I will show you about our preliminary results. The difference between VAMLA and the video mediastinoscopy is the objective. VAMLA has the objective to remove the lymph nodes and the fatty tissue of 3 mediastinal nodal stations. First, the subcarinal, second, the right inferior paratracheal, and third, the left inferior paratracheal lymph nodes. And you can see on the surgical photos how the mediastinum is cleared of fatty tissue and lymph nodes on the right paratracheal area. You can see the superior vena cava and the mediastinal pleura, the trachea. Then you can also see the left paratracheal area showing the left recurrent laryngeal nerve and also the subcarinal station, in which you can see the esophagus and both bronchi. And all of these spaces are really empty of fatty tissue and lymph nodes. So this is the objective of VAMLA. In our preliminary experience with 160 procedures in patients whose mediastinums were normal on CT and PET scan, we had 26 patients, or 16%, unsuspected nodal disease, for a negative predictive value of 0.99 and the same diagnostic accuracy. It is important to notice that when we break down the results according to the N categories and the tumor size, you can see on the left that when there is clinical N0 and the tumors are small, the rate of unsuspected N2 is low, it's just 6%. But when the tumors are larger than 3 centimeters, this rate rises to 22%. And when we have on the right clinical suspicion of nodal of N1 disease, the rate of unsuspected N2 is 40%. We have validated and confirmed these results with 100 more patients added to the 160 patients of these publications, and we have exactly the same results. So there is another point of interest here, left tumors. You see on this left box, the green box, clinical N0, peripheral tumors, or larger or smaller or equal to 3 centimeters. The red arrow points to surgery directly, but the left mediastinum is not the same as the right mediastinum. The mediastinum is not symmetrical. On the left, you have this vascular compound that makes the exploration of the mediastinum from the left side, either by thoracotomy or thoracoscopy, difficult, if not impossible. If you do not explore the mediastinum preoperatively, you will not explore it adequately at the time of lung resection. So it's important to stage the mediastinum in left lung cancer regardless of the size of the tumor or the location of the tumor, peripheral or central. If we do not stage the mediastinum well, you will find this. This is a dark spot in the mediastinum a few months after a left lower lobectomy in a patient whose mediastinum was normal on PET-CT. So this was rebiopsy, this is a tumor, and we can say, well, this is a recurrent tumor. It's not a recurrent tumor. This is progressive disease of tumor that remained unnoticed because the right mediastinum was not explored. So I think these are the 2 points that are important to keep in mind when we look at the ESTS guidelines. And finally, we can conclude that the present guidelines, the ACCP and the ESTS guidelines, have a very high negative predictive value. They are worth using in our clinical practice. If we want to go beyond mediastinoscopy, we can do mediastinoscopic lymphadenectomy either by VAMLA or by TEMLA. Particularly in this situation, clinical N0, clinical N1 tumors, and at the same time, in the left lung cancers, we will rule out clinical N3. As I said before, mediastinoscopic staging is a truly multidisciplinary task, and these staging techniques, EBUS, EUS, and video mediastinoscopy are performed by chest physicians and thoracic surgeons, and there should not be any competition between them. Thank you very much for your attention.